Good afternoon, everyone. This is Katie Cook from Adirondack Health Institute. Welcome to the March Telehealth Learning Collaborative. This Telehealth Learning Collaborative happens every other month and is a joint effort between Adirondack Health Institute, Fort Drum Regional Health Planning Organization, and the New York State Department of Health, who is generously hosting us on their WebEx platform. I sent out the agenda about a week ago, so we are just going to have Amy Smith from OMH go first per her request with any updates from the Office of Mental Health as it relates to telehealth regulations and reimbursement. Amy, I have unmuted your line. I know you had a 2:30 meeting, so I wanted to get to you right away.
Hi, Katie. Thank you. So don't have a lot of updates at this point, just to say that our public comment period is still open for receiving comments up until actually it's like Sunday, March 24th. So if anybody has any comments that they want to send in regarding our updated Part 596 regulations, I would just encourage everybody to get those in so that we can take a look and incorporate any changes if we need to going forward.
Excellent. Thank you so much for that update.
Yep.
All right. And of course, if anybody has questions throughout this session, there is a Q&A box on your WebEx platform. So please make sure to submit those through there and we will answer them accordingly. I'm now going to switch over to our speaker, who is Dr. Pramod Gaur. He's an adjunct professor at Pace University, and he's the former VP of Telehealth for United Health Group. He's certainly a subject matter expert in the field and is going to talk to us for roughly 15 to 20 minutes today about telehealth adoption currently and in a future state, as well as some thoughts on reimbursement, his thoughts from attending the HIMSS conference this year, and where he sees telehealth adoption and growth going in the next several years. So Pramod, I'm going to turn it over to you.
Thank you very much, Katie. Can you hear me?
Yes, I can. Just maybe speak a little bit louder.
Good afternoon, everyone. It is indeed my pleasure to share with you my view of current telehealth, both adoption and barriers, and share with you a little bit of outlook to 2020 and beyond. I've been involved in telehealth for over 20 years in various capacities. At first, as a telehealth vendor responsible for introducing cutting-edge hardware and software solutions. Then, number two, as a partner with a healthcare provider organization for developing and implementing telehealth services here in the U.S. as well as in Canada and UK. And then number three, as a coordinator of telehealth solution for nation's largest private insurance company, United Health Group, where we were looking at how do we address the payment outcome and efficiency. And now I'm an active advocate for digital health. So as Katie mentioned, my intention is for 10-15 minutes to give you some background and then hopefully answer some questions that or some comments you might have. So unlike other industries where digitization has led to rapid adoption and disruption of service models, healthcare is slow to adopt digital revolution changes. First phase of this industry was really largely driven by technology evolution and mostly by industry, where the new technological solutions were proposed. And the key question for almost 10 years was, does this technology work? Can the seniors use it? Or how does it affect to the providers? And I will show you in a minute that it has come a long way from the dial-up and ISDN lines to now high-speed internet, and it continues to evolve there. Then about 6-7 years ago, the question was, okay, the technology seemed to work in at least several of the use cases, but who's going to pay for it? There's no reimbursement. So the next phase of phase came by really driven by the payers who were asking, is this going to be cost effective and the quality of care? And so I'll show you some of the activities that has gone into the second phase. And then we are currently to this third phase where we're saying, okay, technology seems to work. Maybe we have several ways of reimbursement, but where is the outcome? How does that fit into the clinical workflow? How does we get the desired outcome for scalability and sustainability? So let's look at each one of very briefly. As far as the technology, it's now has led to, so there are several components, and let me just walk you through. Number one is the personal devices. That could be any medical devices, your fitness monitors, and any kind of input we needed from the patient. And there was an industry consortium that led to interoperable devices, whether it's a thermometer or pulse oximeters and so forth. They are listed here, that we want to be able to collect the data. Then if you're collecting multiple data, you need to aggregate that data. So then the second part is the aggregation manager. Again, in the beginning, it was a dedicated hardware, but now it's pretty much the software could be adopted to a smartphone, to a tablet, to a PC, and the connectivity also evolved with initially with the wire, USB, to now pretty much Bluetooth, universal connectivity. A lot of it is really the development from the consumer side for Bluetooth, but it's now very well accepted for the medical devices as well. Then once you have aggregated the data, now you need to send it to the patient's health record. And again, in the old days, it was a dial-up on a POTS line, or in the institution, a dedicated ISDN line. But now with the wireless Wi-Fi and high-speed internet, we are able to provide this to a data center. And now in the last couple of years, it's pretty well established a cloud-based data center that takes the information and then shares with the patient record. Again, the key here is the matching, the authentication, matching this information is coming to which patient and date and time stamp. Once it is included in the health record, then it gets to share with the electronic health record or personal health record, and then almost instantly available to a nurse or other care provider or physician if they want to. So this is pretty much is now the standard of the technology, where you're able to take, it's not disease specific, it's now person specific. If a person has you need to measure activities or some vital signs, maybe some questions, you are able to configure for that patient. And you are also able to do a virtual consultation as well. So the technology is now, as I mentioned, is kind of well accepted, continues to evolve, but is stable. So then the question is, who's going to pay for the telehealth? And there were a series of effort that was taken by the payer organization. Of course, the payers, whether it's a private insurance company or the government, their biggest concern is the safety and efficacy, is that access, but ultimately they're concerned about the cost of this service. Is going to be more adding cost to the already skyrocketing healthcare costs in this country. So, for example, when I was at United Health Group and all other insurance companies for a period of 4 or 5 years, we're looking at this virtual care visit. Is it going to be able to solve the problem after 10-minute consultation, or majority of them going to be than follow up in the office visit. And the studies after 4 or 5 years shown that between 70 to 80, 85% of the time when the patient contacts for virtual care, it closes out, for example. And so that has led to a rapid coverage and reimbursement for virtual care, for acute care. Over 90% of employer-sponsored health plan has this benefit. And so that's just as an example. Then the other areas where the payers have looked at is the areas for shortage and as well as providing different service. And now I want to just bring to your attention two references so that what is available for reimbursement. There was a webinar. You have this link here from Arizona Telemedicine Group. Jordana Bernard, who used to be for many years at ATA, now she's at InTouch Health. And this presentation is available, both slides as well as audio. I highly recommend that you look at this. And then, of course, our own Katie has done an excellent job. She did a review for Medicare coverage in December, and just last week she gave another update. So you have a lot of information as to the various reimbursement avenues are open, whether it's Medicare, Medicaid, or private insurance companies, whether through the opioid crisis and others. But that's just saying, okay, technology works, we have a payment, but it hasn't really put into the clinical practice. As I mentioned, over 90% of employer-sponsored programs provide virtual care coverage, but the adoption rate, companies like Teladoc, American Well, and others, the adoption rate is still very low. The only way they're surviving by having the membership usage fees, but not the actual episode. That needs to increase. And that will require where I see now the third phase we are in, where healthcare system, both hospitals and doctors, have to really embrace how this is going to work. And one of the things that I often mention when I meet with any of those stakeholders is that it used to be that, like I said, in phase one, the technology was the selling point, and people will come, myself included, as a vendor in early stages, will try to pitch the technology. We have now reached to the stage where we would like to sit down with the hospital system or a physician and have a dialogue. What are we trying to solve? What problem or what services we're trying to provide, and what kind of population the patient we're going to look at, and then say, okay, here's how we're going to configure the technology is not the starting point. So that's kind of where I think we are come to the point. So there are some, we are right in the middle of this this transformation, the third phase, and there are some early examples of success. So, for example, everybody accepts it, teleradiology, because there was shortage of radiologists in after hours, and so the professional, the doctors, radiologists, accepted that, and they worked with the technology group and created that solution. And another good example is tele-ICU, and it is now well accepted. And several places have shown that by creating tele-ICU, you get better outcome and at a lower cost. And this is particularly very important as throughout the nation and here in our New York area as well, the hospital consolidation going on. So in New York City, these hospitals have purchased up north into Westchester and Dutchess County, and they are able to have these tele-ICU manage larger ICU units. So that's another good example. Then there were some other examples where that business case was readmission penalties. For the last 5-6 years, we've been looking at, say, can this help in terms of post-discharge monitoring to prevent. Then, of course, you have in the last 2 years, chronic care management has emerging, and then value-based, where you have including accountable care organization or bundle payments. And so there are these different drivers that are helping to look at the business case. How do we provide this, to incorporate this technology solution? But I think the main part is looking at, as I want to just mention Dr. Wachter. He's the professor and chairman of Department of Medicine at San Francisco Medical Center. He's the author of best-selling book, Digital Doctor, Hope, Hype, and Harm at the Dawn of Medicine's Computer Age. And he's been named as the most influential physician executive in the U.S. And he was the guest keynote speaker last year at ATA meeting in Chicago. And he, among other things, he pointed out that the next stage of adoption really hinges on reimagining the work itself. So in this diagram, he showed there are two keys to opening in this metaphor. He's using a safety deposit box. So one is the technology, but unless you reimagine the work itself, it's not going to be sustained. If all you have done is you've taken your paper chart and make it a digital chart, but you haven't really changed the workflow. And he used the example was in his institution that the 500-bed hospital, all the patient lab work is done at nighttime. In the morning, when the intern is making round, that's where they look at who needs the endocrinologist or for diabetes complication. And one of the way of reimagining was they had a staff endocrinologist who logs in 6 a.m. in the morning, and in about an hour can go through all this chart with the software, artificial intelligence alerts, can see who would need an appointment for endocrinologist, and hence increasing efficiency tremendously. And so that's the phase I think we are in, where we need to reimagine the healthcare delivery. This is where some of the visionary and more importantly, some of the new members in the medical field will help us reimagine. I put on this chart on the bottom, there are a couple of YouTube link that you may find very useful if you haven't heard of it or if you want to find out. So in closing, so basically, as I look at the outlook for many years, is that you need to look at all the key stakeholders, patients and caregivers. They're increasingly accepting and demanding more on digital health. I'm going to go down and come back around. So payers, I already mentioned, there are more and more ways of paying. Regulators, both policy, the government, again, those two seminars I mentioned, they've all discussed a lot of state and federal level policies. FDA has been very active in this, supporting mobile health technology. And now we are into the provider space where hospitals, clinics, and we need to incorporate this into the workflow. The two main area of focus, one is actionable information, and therefore there's a need. A lot of talk at HIMSS was interoperability with the electronic health records. So if patients' self-generated information is coming, it needs to be integrated into the health record. and then the other part is just fitting into workflow. How do we provide? So with that, I'm going to stop here, Katie, if there's any question and comment.
Not at this time, but I did have a question for you, given that you've been in the telehealth space longer than I have and probably longer than most folks on the line. And one thing that I think looms on a lot of our minds, aside from reimbursement, is the return on investment of telehealth. And you've been in front of a lot of different groups of providers and hospital systems and what have you. And how do you explain how ROI is obtained with telehealth? Because it's not always immediate.
Yeah, that's a very good question. And I think as we are evolving these different evolutions I've described, as it's get driven by the providers, the healthcare system or the doctors, the ROI question will be different because you're not getting reimbursed for the investment of buying the equipment and things. So you are getting reimbursed or included in your calculation is the encounter that you provide. So that means the vendors have already continued to evolve, and they're going to be evolve more into incorporating the solution into the healthcare delivery. So, for example, we do not do the ROI for a MRI machine as to how much it costs. We incorporate that into how the healthcare is delivered. So our thinking of ROI needs to evolve, and vendors are already evolving. It used to be for virtual care, vendors like Teladoc, American Well, Doctor on Demand, they all had a proprietary system, and they're fully just standalone. And now, as it's moving towards from virtual care, acute care, to telemedicine, to probably chronic care, it needs to be built into the operating expense of the healthcare delivery to calculate ROI. That means if they are always having patients to come in person, now they blend in, sometimes in person, sometimes we do virtual. So calculation is going to change. Whereas 10, 15 years ago, we were saying, okay, home care, as we went to prospective payment system, if you have 6 or more nurse visits, and if you can reduce nurse visit, that will pay for ROI. That's not the main driver going forward as the value-based payments come forward.
Yeah, thank you for answering that, and that's kind of along the lines of what I was thinking, is that it's not realized in a way where you're trying to cover your upfront costs. So thank you for that. There aren't any other questions, so if any more do come in, I will connect them to you, and your email is of course up on the screen. So thank you very much for sharing your thoughts.
You're very welcome.
And to move on, a question did come in about OMH and if comments can be submitted this Sunday, the 24th. We are going to wait to hear back from OMH as they check with their counsel's office to confirm if comments come in on a weekend that they will be accepted. So stay tuned for that. Next up on the agenda, kind of going a little out of order, there were no updates from OASAS. However, on the agenda, I have provided an email to contact if anybody has questions about their telepractice regulations. I know that after Thursday's telehealth reimbursement webinar that I did, that there were numerous questions that came in about the requirement for an additional face-to-face evaluation for buprenorphine induction. So those questions have been forwarded to OASAS, and I am awaiting a reply, so stay tuned. Additionally, probably top of everyone's mind was having someone from the New York State Department of Health on the line to answer questions about their new special edition telehealth update. Unfortunately, Jonathan Lane had a last-minute prior commitment that he had to attend to, so he is not on the line today. I do have a couple of quick updates from an email I received from him. Oh, wait, he actually is on the line. Hold on. I'm actually just going to unmute him. So, Jonathan, you're unmuted if you wanted to provide any thoughts or updates or who to contact with questions for the special edition telehealth update.
Sure. So this is Jonathan Lang. I'm taking the lead for Joan Sicard, who we all love and adore, who's recently retired. The best way to send me questions is to send them to my email address, which is Jonathan, JONATHAN, .lang, LANG, @health.ny.gov, and I will try to turn those around as quickly as I can.
Thank you, Jonathan. Yes, I know there's been a lot of questions I've been throwing your way, so I appreciate your due diligence in getting back to me so quickly. So yeah, for anybody on the line who still has outstanding questions from that update or from the webinar that I did, please direct them to Jonathan for further follow-up. You know, a couple of things I wanted to note, there's been a lot of questions about OPWDD guidance, which, as you had mentioned, is currently under internal review with their leadership team. So as soon as I see that guidance or that administrative directive memo, I will be sharing that with the group at large. And additionally, this special Medicaid update that DOH has released is a finalized document, so it won't be going through a public comment period. There is one question that just came through. It's not a question. Dr. Carigliano, if you want to submit that through the Q&A box, I'll be happy to address that. Just moving on through the questions here, Jonathan, I did get one, so bear with me while I pull it up. I'm just waiting for the rest of it to come through. It's kind of cut off. Okay, it's more a comment around reimbursement in New York State is prohibitively low and New Jersey is much higher. I don't know, Jonathan, if you have any thoughts on that. I mean, this update is finalized at this point. I don't know if that particular individual is what they're referencing, whether it's telemedicine or store and forward or remote patient monitoring, but I can say, and Jonathan, you'll probably agree, is that compared to the previous Medicaid update from March 2015, the rates have increased. So we are moving in a positive direction, I think, as well as allowing the patient's place of residence to be an eligible site.
That's correct.
And another question did come through, how can we advocate for New York State Medicaid reimbursement to make telepsychology therapy sessions more financially viable?
So is that a question directed for me, or?
I would believe so, because it does reference New York State Medicaid, maybe who they can reach out to. It does say how can we advocate. So for telepsychology therapy sessions, who would be the best person to talk to about that?
Well, if you can send the initial question to me via email at jonathan.lang@health.ny.gov, and then what I'll do is I can circle back with our small group of state agency reps, including OMH, and we can have a conversation about that.
Okay, thank you. And thank you for getting on the line and providing your direct email. I do appreciate it.
No problem.
So I don't see any other questions at this time. Again, feel free to reach out to Jonathan, or if it's unrelated to New York State Medicaid, of course, myself and I can do my best to try and help out with that. And another question did come on, Jonathan, which I know you had responded to me earlier about regarding the update. Can you confirm that the place of service that must be listed on a claim is only place of service code of 02?
Correct.
Okay, thank you. All right, so updates on the North Country Telehealth Partnership. There are no updates currently from the Fort Drum side, but I did want to put on everyone's radar that the 5th Annual North Country Telehealth Conference does have a finalized date and location. It will be on Wednesday, November 6th and Thursday, November 7th, and that will be at the Fort William Henry, which is in Lake George, New York, which is roughly 10 minutes north of where I'm located in Glens Falls. So stay tuned for a save the date as well as a call for presenters. Just want to get that on everyone's radar now, as that is typically an event that sells out. If you're looking for other telehealth related conferences or events to attend, there are several coming up. There is a telehealth symposium on Monday, April 8th and Tuesday, April 9th, and that is in Tarrytown, New York, just 45 minutes north of New York City. That is being put on by Chicanes. And if you go to Chicane's website and click on their events tab, there's more information on that conference. They're having a wonderful agenda put together. I will be there speaking in addition to the team from Finger Lakes Community Health, Mary Zelazny and Cyrene and Casey, as well as folks from HRSA, folks from different legal organizations, the National Association of Community Health Centers. So check that out, and if you can attend, that would be a great event to go to. And of course, my colleagues and friends at the Northeast Telehealth Resource Center have released their date and website for their conference, which is going to be on, and I'm just double checking, so bear with me, it's in June. And it is on June 17th and 18th of this year at the Westin Portland Harbor View in Portland, Maine. The call for presenters has ended, but you can register if you go to conference.netrc.org. There's more information, including how you can register different sponsors, costs, and all that. I find that to be a fantastic event and one worth attending. Other than that, I did send out the slide deck and recording to the webinar I did on Thursday regarding the 2019 telehealth regulatory and reimbursement updates. I am still working through a lot of the questions I received, so if I have not gotten back to you, I am not ignoring you. I just received a lot of questions and I want to make sure I answer them accurately or give you the right person to talk to. So I don't have any other updates, so I just gave you a half hour back of your life. I did get one question about the Chicane's website. So the Chicane's website is actually chanys.org. I'm just confirming that right now. Yep, chanys.org, and that's where you'll go to look up the conference there. I also forgot to mention the American Telemedicine Association conference is April 14th through the 16th in New Orleans. That is a very massive conference, but they really bring in some of just the absolute best of the best from around the world with telehealth. So lots of different events to attend, and I did also hear back oh, never mind. So yeah, the ATA is the other conference to attend. I have no other updates, so we will wrap it up for today. I'll send out some notes and the slide deck, as well as the recording later this week. So thank you so much for attending, and stay tuned for an update on our next session, which will be in May. If you are interested in speaking on this Learning Collaborative, please reach out to me. My email is kcook, KCOOK, @ahihealth.org. Have a fantastic day.